David, so great to see you.
You too.
Hi. So, well, let me do some introductions. I'm Nancy Ramamurthi. I'm the CEO of Proper. Proper is a new kind of sleep wellness company. What we're doing is we offer a line of natural, safe, and evidence-backed supplements combined with expert behavioral sleep coaching that you can access digitally. So that's my little plug and an intro. And let me, I'm so thrilled to be interviewing Dr. David Casarett. He's an advisor to us. And he is also a professor of medicine at the Duke University School of Medicine and chief of palliative care for the Duke Health System. He's the author of more than 100 journal and numerous magazine articles on healthcare and medical cannabis, and is particularly interested in the ways that healthcare can become more person-centered. I love that. Many of you may have read or heard of his 2015 book, Stoned, A Doctor's Case for Medical Marijuana, or you may be familiar with him based on his work with several companies in the cannabis industry, including Canopy, Melix, Curio Wellness, Curaleaf, and Clever Leaves. Like I mentioned earlier, we here at Proper are proud to be working with David as one of our advisors. He's been helping us with our line of supplements, and we are launching, sneak peek, our CBD product also. So please, all of you at the conference, feel free to check out our site and purchase. But at any rate, let me get right to it. So David, everyone here who's listening into this, participating in Growth at Home, is interested in the future and the potential of cannabis, I think, for helping people live better lives, just at a fundamental level. So can you talk to a little bit about the science that we know, whether it's definitive science or emerging science and other proof points around how various cannabinoids, THC, CBD, CBN, et cetera, can help people lead healthier lives ultimately. And let's focus on, I guess, a few key areas. So let's talk about sleep, since sleep is something that is near and dear to my heart. But cannabinoids and sleep, what do we know for sure, and what's emerging?
Sure, and I think that's the best way to tackle this, to think about a variety of indications. There's a lot of discussion now about whether cannabinoids work, and that's not really the right question to ask. The real question to ask is what they work for, how they work, how much we know about whether they work, and to really think of it in more scientific terms than just cannabinoids good or bad. Mm-hmm. And I think it's great to start with sleep, both because I think there's it's safe to say a lot of anecdotal evidence out there about sleep. I told a patient once, there hasn't been a whole lot of randomized controlled trial data about cannabinoids and sleep, and she said, well, you don't really need a whole lot of randomized controlled trial data to know that cannabis and THC in particular helps you go to sleep. But she used the example of a parachute. You're falling out of the airplane. Somebody hands you a parachute 20,000 feet up. You're not going to say, well, nobody's ever tested parachutes in a randomized controlled trial. It's pretty obvious. Having said that, though, I think we'd all like to see more randomized controlled evidence, both to document that cannabinoids and THC in particular really are helpful for sleep. We'll talk about CBN maybe a little bit later. I think a lot of interesting data emerging about the potential for CBN in sleep that hasn't really been studied. And I would love to see more evidence showing not just that THC improves sleep, which I think seems pretty plausible, but how does it work? What effect does it have on sleep latency? What effect does it have on overall sleep quality and sleep efficiency and feelings of restedness in the morning? And I think those are all the things that drive people to make changes. And those are all the outcomes that are important to people. And so, although I think at a high level, it's pretty safe to say that especially THC, probably some combination of THC and CBD, probably CBN to improve sleep. I would love to see a lot more research helping us to understand exactly what's in that black box. What does that mean, and what does that look like?
Mm-hmm. And so, in terms of actually, I'm curious. I guess there's been some studies that have been done, not necessarily among healthy adults, but for CBD and THC in terms of the reduction of stress and anxiety. Can you talk a little bit about that?
Yeah, it's fascinating, because that's another category where the anecdotal evidence is pretty strong. I mean, mm-hmm. I think if I had to guess, I'd say across the board, stress, anxiety, whether that's clinical anxiety disorders or just a sensation of anxiety, is probably one of the, if not the top reason for cannabinoid use, at least where it's been measured. Again, we don't have a lot of of evidence, but I think the evidence that does exist points to pretty strong effects of some combination of THCs, CBD, and CBN.
Mhm.
And we can talk about PTSD maybe a little bit later, but that's certainly a use case where there's a lot of enthusiasm for the use of some combination of THC and CBD, and ideally potentially the whole plant. And I'd be the first to admit that PTSD is not anxiety. It's in many ways much more complicated. But some of the features are similar enough that when you get hundreds of people saying that some combination of THC, CBD, or whole plant cannabis helps with anxiety, there's got to be something there. You have to be a little bit careful, I think, sometimes about withdrawal. I don't think withdrawal from cannabinoids is as big a problem as many people make it out to be. But I do talk to patients who say they use cannabis or some THC containing preparation regularly. They stop using it and their anxiety gets worse. And I think at least some of that might be a phenomenon of withdrawal. But I think the combination of a lot of anecdotal evidence, a lot of prospective evidence, including, which we can also talk about later, some evidence that cannabis can be very helpful in helping people to stop taking benzodiazepines, for instance, for anxiety disorders. And that, to me, is some powerful evidence that there may be something there. People are getting off of their Xanax and Ativan and using cannabis instead. There's got to be some effect, which I don't think, again, we understand the mechanisms nearly as well as we could, but I think that effect is probably real.
Have you seen this? Have you heard about this, or have you seen it with your own patients in terms of the cannabis usage and getting off of the benzodiazepines?
Yes, I certainly have. And both benzodiazepines and opioids. I take care of patients many of whom are near the end of life, or patients who are struggling with advanced serious illnesses like cancer or heart failure. And that's usually in my differential diagnosis when somebody says their pain or their anxiety is better controlled and they don't need as much of the opioid or benzodiazepine as they had been taking. One of my questions, usually carefully phrased because I practice in a state where cannabis, or at least THC containing products, are not legal. It's a potentially sensitive question, but I always feel the need to ask, and not infrequent that the answer is I've started using some combination of THC, CBD, cannabis, hemp oil, to which they attribute some of their improvement. And I have to say, just anecdotally, I think that effect is real. And what's maybe most important, the desire for that effect is extraordinarily real. There are a lot of people out there, many of whom are friends, family members, who don't want to be taking opioids, don't want to be taking benzodiazepines. And if they have trouble sleeping, don't want to be taking prescription sleep aids. They'd like to be taking care of their own needs more naturally. And just because people want it to be true, that doesn't mean it's true. So let's be real about that. But I do think that it is something that needs a whole lot more research, because although there is this perception, I think, among physicians that patients just want drugs, they want opioids, they want benzodiazepines. Among my patients, the truth is actually quite different. They would be much happier if they could get off of these medications and use something natural instead.
Yeah. That's, I think, how you originally got the inspiration, right, for writing your book.
Right, talking to a patient who asked me about medical cannabis. I told her I didn't really know. I wasn't sure what the evidence was. And she said, well, it works for me. And this is a retired professor in her 80s. And it made me realize that if cannabis works treating cancer-related symptoms for a retired professor in her 80s, there may be some science to that.
Yeah. So that brings us to cancer, actually, which was one of the other areas that we were going to discuss. What cannabinoids might do in terms of helping people address some of the associated issues that come with cancer.
Yeah, and I'm glad you phrased the question that way, because I think when we talk about cannabinoids and cancer, there are two ways that question is framed. One of which is, can cannabis or cannabinoids help to relieve some of the symptoms of cancer? Number one. And two, can cannabis or cannabinoids treat cancer? And those are two very, very different questions with different answers. And the first question about symptoms the answer is really very exciting. I think we've known for a while, probably not as good randomized controlled trial evidence as I would like, but pretty good that cannabis and THC in particular can be helpful in chemotherapy-induced nausea and vomiting. I wouldn't recommend it to a patient as first-line therapy. There are other drugs out there. But for people who really have a difficult time or who want to avoid some of those medications, I think, and it's probably a serotonergic mechanism, I think there's good evidence there. Certainly the elements of cancer that are associated with a loss of appetite and lack of enjoyment of food, I think there's good evidence. And for the THC evidence predominates, but that's only because some other cannabinoids, I think like CBD, CBN, CBG really haven't been studied. Neuropathic pain associated with chemotherapy, either acute pain during the course of chemotherapy or pain that can come on after the chemotherapy is over, particularly for platinum-based therapies. Again, not a lot of evidence, but I think we do have decent evidence that cannabis, usually a THC CBD combination, can be useful for neuropathic pain. And certainly anecdotal evidence. I think that's very, very interesting. I think where things get a little bit tricky is with the second question about whether cannabis can treat cancer. And when I have this conversation with my patients, I'm usually very careful to say that as far as we know, cannabis doesn't treat cancer. And that's really an answer that's born out of my experience and patients I've known, including one I interviewed when I wrote the book, who was a lady single mom with 2 children. She was in her late 30s, early 40s, was diagnosed with an advanced lymphoma that was very aggressive, but also very treatable. Probably would have had an 80 or 90% 5-year survival, in effect, a cure rate with a bone marrow transplant. But she was overwhelmed with childcare and her life and the toxicity of chemotherapy. And when somebody told her that using cannabis was as effective as chemotherapy and a bone marrow transplant, she stopped going to her oncologist and put all her faith in concentrated THC infused oil. And she died 4 months or so before the book came out, leaving 2 kids behind without any parents. So whenever anybody asks me about the benefits of cannabis for cancer, I usually tell some version of that story or at least allude to the evidence. It's fascinating though. I mean, I think there's some very interesting preliminary evidence from in vitro studies. We know that cannabinoids, for instance, reduce the rate at which tumor growths create new blood vessels, so-called neovascularization. And that's one of the hallmarks of the way cancers grow and spread. And there are other indications too that there may be effects of THC, CBD, other cannabinoids that could slow or even reverse the growth of tumors in people. So I'm not saying there isn't science there. I think it's very interesting. And I wouldn't be surprised if 5 years from now, cannabinoids or derivatives are some part of chemotherapy, but it's too much to put your hopes in right now, I think.
Who's doing that research right now?
That's a good question. Yeah. I think some of the most exciting research is coming from other countries. It's maybe we'll talk about this later, maybe we won't, but it's really hard to get federal funding for therapeutic uses of cannabis and cannabinoids in this country right now. So I think some of the most exciting research, because of legal regulatory concerns. So some of the most exciting research that people still cite, even 10, 15 years later, related to the use of cannabinoids and THC in particular on malignant brain tumors, comes out of Spain, where there's a group, Dr. Guzman and others, who have been doing this work for years. I would love to see the United States catch up. That would make me very happy, and hopefully we will someday. But right now we're a little bit behind, and some of the best research is coming out of Europe and Canada.
All right, let's talk about pain and ingestible cannabis or topical. How effective cannabinoids may be for addressing pain.
Yeah, pain is fascinating. I think cannabinoids have been studied for pain probably longer and if not longer, then certainly more thoroughly than they have for any other indication. We certainly have the largest number of studies, I think, for cannabinoids and pain. So in one sense, we have the most evidence for pain as for any indication. On the other hand, those data are still pretty mixed. So I'll give you maybe not a flag in the sand assessment of what the evidence shows, but kind of my read on it, which is for nociceptive pain, which is more classic pain that you might experience with a back injury or a broken leg or swelling after a soccer injury. The evidence is probably good enough to warrant its use for chronic pain. I should say that quickly for acute pain that might last for a day or two, there probably isn't a whole lot of evidence for cannabinoids. But for chronic pain that's nociceptive, I think the evidence is probably good, but mixed. My own view is that the evidence for neuropathic pain, so pain that's due to a nerve injury, which might be post-traumatic, it might be after chemotherapy or other pharmacotoxicities from therapy, sometimes musculoskeletal disorders, entrapment syndromes. For those situations, I think that the evidence for cannabinoids is probably better. Although even there's some disagreement. Mark Ware, who's an outstanding neurologist, pain specialist at McGill, did one meta-analysis that found that it was effective. The Cochrane group, I think out of Germany, did another meta-analysis and found that it wasn't. And they were looking at very similar groups of studies using similar criteria. So there's still some room for interpretation. But I think the weight of the evidence, for me at least, as a physician, would suggest that for neuropathic pain, so pain due to a nerve injury, cannabinoids can be effective. What the optimal set of cannabinoids is for either one of those indications, nociceptive pain or neuropathic pain, I don't know. There's an anesthesiologist named Barth Wilsey at UC Davis who, last time I spoke with him a year or two ago, about a year ago now, was very interested in the benefits of CBD in particular. And instead of typical preparations that might be, a 10-to-1 THC to CBD ratio, pushing that closer to 1-to-1 or even flipping it. He was really convinced that there might be some benefits to CBD and maybe other cannabinoids that we hadn't identified. So I'm not sure anybody really knows, but I think that particularly for neuropathic pain, I would not be surprised if CBD in particular, and maybe some of the other understudied cannabinoids like CBN might have a role to play.
Interesting. And so what about other areas that you think cannabinoids may play a role in terms of helping to address? I think you had mentioned bone marrow transplants.
Yeah, I'm glad you asked about the other group because I kind of feel like a lot of the attention for cannabinoids on pain or anxiety is maybe the evidence is there. I think it is, and I think there's some legitimate use cases, but I also feel like we're missing the boat. And I had the opportunity when I was writing a book on this to spend some time in Professor Meshulam's lab in Jerusalem and to spend some time with him and his crew of graduate students. And I was fascinated by the conversations that went on there. It really wasn't about whether cannabinoids work for pain. It was really about what are the mechanisms by which cannabinoids act and how could you use those mechanisms to begin thinking about other potential use cases. Professor Meshulam and I had a conversation over lunch where he explained to me where he thought cannabinoids might fit into epigenetics, meaning how genes are turned on and turned off, and how that might regulate everything from development to personality. So I think those are the really interesting conversations to have. So I'm glad you asked about other use cases. Thinking through a list, I can give you maybe my top 5 or 6. Some of which we've alluded to already. Opioids, benzodiazepines, for instance. I think, although I haven't seen any high-quality randomized controlled trials, there have been a couple of good prospective studies that have found that people who begin using cannabis can reduce opioids and benzos. And, some of it's probably the placebo effect. And maybe some of these people really wanted to stop using opioids or benzos, and maybe they would have stopped if they had just enrolled in a trial with a little bit of psychosocial support and coaching potentially. But the weight of the evidence, I think, is starting to move in the direction that there may be some effect there. I guess related, one other study I read about probably in the last year or so came out of Mount Sinai, was a study that it enrolled patients who had a history of heroin addiction and used CBD to try to interrupt the cycle by which visual triggers are cues for craving. So that's often one route of relapse in a variety of addictive disorders, visual cues, whether it's of a heroin needle or even exposure to the site where somebody is traditionally used, or settings or people that are associated with use that can trigger a craving. What they were able to discover was that fairly large doses of CBD reduce those craving responses to the visual stimuli. And that's not the same thing as treating addiction. It's not the same thing as preventing relapse, but it's a really interesting way to think about treating addiction. And it's a very, very interesting potential role for CBD and cannabinoids. Again, totally separate from the usual uses that people talk about of pain and anxiety. Some other neat studies out there. One I remember looked at people who were either HIV positive or at risk for HIV. It was part of a larger prospective study, and found that cannabis use was associated with a decreased risk of type 2 diabetes. What does that mean? Well, maybe nothing, but we know a lot about the role that CBD has on modulating inflammatory responses. And we also know that inflammatory responses are key to the development of type 2 diabetes. And so putting those together makes me wonder whether there may be some effects there. There are other use cases, autism, a few trials that are underway, and a fair amount of anecdotal evidence, and a lot of parents out there who are absolutely convinced that some combination of cannabinoids are helpful. I think I don't automatically accept anecdotal data, but when it comes from so many parents from so many countries around the world, you've got to really wonder whether there's something there. PTSD, I guess we mentioned before. Again, there hasn't been a good randomized controlled trial. I think everybody was hoping to see Sue Sisley's study published. But I think, again, there's so much anecdotal evidence and so many surveys of patients who are struggling with PTSD saying this helps, and this is the only thing that helps. I think either there's an enormous placebo effect there, or there's something there. And last but not least, you mentioned bone marrow transplants, and I guess that's part of the larger question of the immune system. I think we're learning a lot about how THC and CBD in particular modulate the immune system. And some interesting prospective data that I've started to see, not published yet, so I can't cite where it comes from, that has not proven, but begins to suggest that CBD may be useful in preventing graft versus host disease in bone marrow transplants, which is the response that the body wages against cells in the setting of a transplant, foreign cells. And that is interesting to me mostly because it opens up what I think is a potentially large field of research. And I'm not saying we should stop thinking about pain and sleep and anxiety, but I think there are a lot of other interactions between cannabinoids and the endocannabinoid system related to inflammation in particular that warrant a lot of research, because I think there could be some really cool studies there.
Interesting. CBD research here in the US, what are some of the studies that you're familiar with that are happening right now?
Well, I think some of the most interesting studies are, actually one of the coolest studies is one that's being perpetrated by a friend of mine, Donald Abrams at UCSF, who is, I think, I don't know, if Raphael Mechoulam is the grandfather of medical cannabis, then Donald Abrams is probably the friendly, funny uncle. He has certainly been doing this work longer and better than pretty much anybody else in the field right now. He's done a lot of really fantastic work that leverages his background as an oncologist. And he's actually the one who got me interested in some of the in vitro work that's being done on THC, CBD, other cannabinoids on tumor responses. Mm-hmm. And so he's doing a study now, which I think is still ongoing, looking at CBD in sickle cell pain and pain crises, which is interesting because it's pain, but the pain crises in sickle cell are not just simple pain. They're due to what are called vaso-occlusive crises, when blood becomes thick enough or tenacious enough so that it doesn't move through smaller blood vessels adequately, and causes severe pain that typically requires inpatient hospitalization. And so his thesis is, because of what we know about CBD and its effect on inflammation and potentially its effect on blood clotting, that this may be a simple, essentially non-toxic way to prevent these pain crises that are obviously very, very uncomfortable for patients, debilitating, disruptive, and also lead to opioid use. So his thesis is, if CBD could disrupt that cycle, that would be really exciting, and I think one of the most important advances in sickle cell management in the last 10 years. So that's just one example. I think other examples are more prosaic, but probably also will move the ball forward. Trials going on now for some combination therapy for CBD and sleep, CBD and anxiety, and the work that I mentioned before in graft versus host disease in bone marrow transplant patients. And I give you that's probably not a complete summary of all the research that's going on out there right now, but I think it's interesting because it gives you a sense of the breadth of work that's going on, which I think is really exciting in this field.
This leads me to the next question that we were thinking about was, do you think we're learning as fast as we could be? So what are some of the barriers, and how could we kind of accelerate research around some of these benefits?
Yeah, it's a great question. I don't think we're learning as fast as we could be. We're not learning as fast as we should be. And frankly, if we have a product, which is cannabis, although I realize it's not one product, it's a variety of different products depending on which strain, and whether it's CBD or THC or other products. Mm-hmm. But you've got something that not just thousands or tens of thousands, but millions of people around the world are using. We really should be getting a whole lot smarter about what it does. This is not something that's being used by a handful of people in a small rural county in Iowa. This is something that is pretty much global. I don't think we know nearly enough about what it does, how it works, how it could work better. So I think research is needed. How do we do that? I think we need funding, first of all. It's actually not rocket science. If you want to do research, you need to fund research. And if you want to fund research, then somebody has to fund it. And the United States has been really, really slow. It's not impossible, but it's very, very difficult to get federally funded research. Even if you get federally funded research, it's hard to get access to cannabis products that are sanctioned by the federal government. The University of Mississippi has had a lock on that market for a long time. And nothing against the group there, but I think if we want to diversify research, if we want to build a research portfolio, we really need more strains, more combinations of THC, CBD, other cannabinoids to test. So I think funding, rethinking regulation. Should cannabis really be Schedule 1? I don't think so. I really don't. I don't think it's as toxic as other things like morphine that are Schedule 2. Doesn't make any sense to me. So that's one thing. And I think the other thing we could do to accelerate research is to learn from those millions of people who are using cannabis or cannabinoids every day. There's a lot of data that's just evaporating. Data about effectiveness, data about safety. Every time somebody uses a cannabis product, that's an opportunity to learn. and to help the next person who uses a cannabis product use that product a little bit better. But 99.9% of that data is just going up in smoke, and that's really a shame. So yes, we need funding. Yes, we need better infrastructure for randomized controlled trials. But we also need to get much better and much smarter at learning from those people who use cannabis and cannabinoids every day.
It's hard to, look into a crystal ball, but in terms of the regulatory, do you see that changing, and in what time period?
Well, I think things may change long about November 3rd. I don't have a crystal ball. I really don't. I've been very intrigued by the policies of the U.S. administration relating to cannabis, the current administration, and the soothsayers and oracles who are trying to divine the opinions of Vice President Biden and Senator Harris. I think if I had to offer a very uneducated guess, you should really turn to the pundits for an educated guess, although I think the pundits 4 years ago were predicting a Hillary Clinton win, so maybe you shouldn't believe them. Maybe a dumb doctor from North Carolina is as good as you're going to get. But I think I would hope that rescheduling is at least a possibility, because it really would open up the ability to do research. And that's not a topic that I think many people could seriously oppose. I had the privilege of doing a congressional briefing on the Hill a couple of years ago, and there were, in addition to staffers, both senators and congresspeople there. And the one element that was mentioned in that briefing that got widespread bipartisan support from that little room, granted not a random sample, was reducing barriers to doing research. And I think rescheduling would certainly do that. There are certainly those who say we should deschedule. I think those are much more complicated decisions. But I think the ask to reschedule and to open the door to more research, both related to potential benefits and risks of cannabinoids, that's something that I think most people in Washington, I hope, would support. So that would be, if I had a prediction, it would be some movement to increase research, potentially probably through rescheduling, would be a realistic, I think, hope with the new administration within the next year timeframe. But again, that's me as an outsider, not as a pundit who watches these things closely.
Interesting. I guess switching gears a little bit, there's a lot of out in the marketplace, whether it's THC or CBD, there's a lot of interest and conversation and marketing around more personalized dosing and really understanding what's the right dose for a consumer. What's the truth on this? Like, what do we know and what don't we know? And how precise can we really be?
Yeah,
does it matter? How much does it matter?
Well, I think you got to start with the assumption that it matters until you get evidence that says it doesn't matter. Because for a lot of other drugs, and THC, CBD, CBN, they're drugs, just like amitriptyline or morphine or acetaminophen are drugs. For a lot of drugs, we know that there is some variation among people with respect to how they metabolize a drug, how that drug binds to receptors, for instance. And so it's not like we're new to pharmacology. We've known about these inter-individual variations for decades now. And so to go into the discussion about cannabinoids thinking, well, yes, we know there's lots of inter-individual variation with other drugs, but cannabinoids is probably one size fits all. That seems to be misguided. It may turn out to be true for the most part, but I think we have to assume that there's some variation, number one. And number two, we know that there is. So I'm talking as if this is purely hypothetical, but we also know that it's not. For two reasons. One, we all have different enzymes, not vastly different, because if we all had random enzymes, we wouldn't survive. There's a reason we have the structures, the biological infrastructure that we do, because it's compatible with life. But within some pretty tight parameters, there actually is a fair amount of variability. Some people metabolize ethanol, alcohol, more quickly than others. And that leads in some populations to adverse outcomes from even a little bit of alcohol. We know the same is true for opioids. There's some enzyme polymorphisms that are associated with a faster or slower metabolism of opioids. Often not enough to worry about clinically or to test for, but something certainly to be alert for. And there's growing evidence, and full disclosure, I have an equity interest in a company called Melix that makes a test for both enzyme polymorphisms and receptor polymorphisms to try to predict how people respond to opioids and cannabinoids and other drugs. But that product is based on a interesting and preliminary, but I think still already pretty solid science, that just as people have different characteristics, our noses look a little bit different, our chins look a little bit different, our enzymes and receptors look a little bit different. And in somewhere between 5 and 10% of the population, sometimes a little bit more, often less, there are people who have either receptors or enzymes that behave substantially differently. Enzymes, for instance, that are very, very slow to metabolize CBD or THC, which means a lower dose is as effective as a higher dose, which is something you would want to know. And other enzymes are associated with some of the dysphoric effects, for instance, anxiety, paranoia, hallucinations that are associated with THC in particular. And some of those enzyme polymorphisms are also associated with an increased risk of addictive behavior related to cannabis. So if there's one lesson here, it's that these polymorphisms probably don't occur in 40, 50, 60% of the population. They're by definition rare. There's a typical enzyme, and then there are enzymes that are uncommon. But they're additive. You may not have variation 1 or 2 or 3, but you might have variation 4. And when you think about this on a population basis, I think it is something that's important to know about, especially when you factor in different responses to other medications like opioids. So I think there's good science out there, and that science is getting clearer and clearer every day, that you and I respond to cannabinoids differently, or we may. And that may have implications for how we use cannabinoids therapeutically. I think what we struggle with now clinically, meaning we as a clinical medical community, is we don't really know what those are. Those tests aren't widely available. They're certainly not widely used. And so the general guidance is to start low and go slow. That's more important for THC containing compounds as opposed to CBD, which doesn't have any meaningful toxicity. On the other hand, you don't really want to give anybody any medication that's in a larger dose than what they need. So it usually makes sense to start low and go slow, even if toxicity isn't a concern, as it is not for CBD. I hope that science will become more clear as time goes on. And what I would love to have happen is not just more clarity about dosing and individualized dosing, but potentially even individualized use cases. I think we've learned a lot. Actually, the science of these receptor polymorphisms and their association with various diseases is fascinating. We know that some receptor polymorphisms, some versions of the receptor, cannabinoid receptors, are associated with conditions ranging from osteoporosis to diabetes to anxiety, which doesn't necessarily mean that cannabinoids per se are involved in the creation or even the treatment of those disorders, but there's some link there via the endocannabinoid system. So I just mentioned that to say that I think our individual responses and the inter-individual variation in our responses to cannabinoids is one side of the equation. But the other, which is equally, if not more fascinating, is that some of that variation may tell us something about how cannabinoids are involved in osteoporosis or obesity or diabetes in ways that I think at least I'll speak for myself, I can't begin to comprehend right now. But hopefully will become more clear in my professional lifetime.
Well, I'm very excited. It sounds like we're just at the very beginning of what could be a world of very interesting research. I hope things do change. Is there anything else that you think that excites you about the future of kind of the research and the learnings ahead about how fundamentally cannabis and cannabinoids could help people lead better lives?
I think so. The one thing that excites me most, this is a little bit nerdy, so probably not the thing to drop at the end of this interview, but I've been thinking about it a lot lately, which is it feels to me like cannabinoids are a really rough and ready way of helping us learn about the endocannabinoid system and how the body works. Mm-hmm. And it may be that 10 years from now, nobody's using cannabis. Nobody's even thinking about THC, but we're thinking about the endocannabinoid system in new ways. An example for that is 100 years ago, people used to use cod liver oil because it had health benefits that were kind of ill-defined. It was good for pain and fatigue and bone health and growth and strength and a few other things, but nobody had any idea what it did. People finally figured out, though, that the active ingredient in cod liver oil was vitamin D, and then vitamin D became the key, if you will, to unlock a lot of valuable information about how bones grow and get remodeled, which has led to a lot of initiatives in understanding bone health and aging. We understood a lot more about muscle density and muscle mass. It helped us to understand about how the kidneys process calcium and phosphate. So that one little bottle of cod liver oil, nobody uses cod liver oil now, but that's what made it possible to understand these very complex systems. And I kind of think about cannabis and cannabinoids in the same way. We may not be using cannabis medically, maybe still recreationally, but medically 10, 15, 20 years from now. But it will have unlocked some of these other secrets. And that to me is very exciting. And then to maybe end on a less nerdy note, I think the other thing that's really exciting to me about cannabis and cannabinoid science is so much of it happens outside the doctor's office. And so much of it is about giving people really a chance to control their own lives. And these are people, many of whom don't want to be dependent on medications, certainly don't want to be dependent on a doctor's visit or a doctor's prescription pad, really want to manage their own health. And cannabis and cannabinoids are one way that they can do that. And I think as a field, we really owe that large population of millions of people every day who are using cannabinoids. We owe them the research to help them make better decisions. And I think if we do this right, the result could be really, really, really exciting, both for individual patients in need, but also for healthcare and the way that healthcare is delivered.
Mm-hmm. I'm curious, what do you think about the research around the negative effects of THC, particularly in young people?
Yeah, I think I would divide negative effects into two categories. There's the negative effects that adults experience, and those range from acute effects of dysphoria, anxiety, paranoia, addiction, driving impairment, and potentially, I put this one in a couple of parentheses, but I think it's real, the potential for long-term cognitive impairment with really, really, really heavy use. I think all of those effects, I think, are real. Again, I'm hedging my bets on that last one because I think the data are conflicting, but I think all those things are real. And I think those are risks that honestly are usually pretty modest, but people should be aware of. It always concerns me when people talk about using cannabis. And I had one dispensary owner once tell me that cannabis is a flower. It's not harmful. It can't be addictive. It's not like morphine. Not realizing that morphine is an opioid. Opioids come from poppies, which are, last time I checked, also flowers. There's the sense that because cannabis is cannabis, because it's natural, it can't be associated with any risk. I mean, anything has a risk if used in the right or wrong way or dose. And that's not to be an indictment of cannabis or cannabinoids. I'm a palliative care physician. I prescribe opioids all the time. And I realize they have risks, but I prescribe them anyway because the benefits for that patient outweigh the risk. And I talk with patients about those benefits and risks, and we decide that's the best option for them. And I think as long as we're doing that for cannabis and cannabinoids, then I think that's good medicine. What you asked about was the use in teenagers, and that's something that makes me a lot more nervous because for my money, I don't think we know nearly as much as we should about long-term brain effects of the use of cannabinoids in general and THC in particular in developing brains. And by developing brains, I think for me, that's anything under 21. But I think what we do know is concerning. And certainly the signals for MRI imaging and neuropsychiatric testing makes me concerned that there are some effects that we need to be careful about. Recreational use for teenagers, probably not a good idea, certainly regular recreational use. But there are these corner cases of kids 3-4 years old whose seizures don't respond to anything else. And I would never tell one of those parents, well, you shouldn't use a THC containing product for your kid because there might be long-term effects. Those are loving, caring parents trying to do the best thing they can for their kid, whether it's a 3-year-old with seizures or a 13-year-old with leukemia. And I think that same conversation needs to happen about risks and potential benefits. But I think the set point needs to be a little bit higher, and we need to be more careful for teenagers, particularly with developing brains. And we also need a whole lot more research. I would love to see much more research about safety for cannabis, both for adults and for kids.
Awesome. Thank you.